He was 52 years old, worked as a civil engineer, had a beautiful family, 3 kids, a life that anyone would call successful. I met him on a Friday morning when he walked into my office with what seemed like a simple complaint. He'd been feeling way too tired for the past few months. He said he figured it was work stress, said he'd feel better over the weekend. I looked him over, asked the standard questions, ordered the labs. He left smiling, thanked me, promised to come back the following week to get the results. He never came back. 3 weeks later, I got a call from his wife. She was crying so hard she could barely speak. He had slipped into a diabetic coma at home in the early hours of a Tuesday morning, while everyone was asleep. The paramedics got there fast, but it wasn't enough. His blood sugar was 748 mmHg when he arrived at the emergency room. His kidneys were already showing severe signs of failure. His heart didn't make it. She said something to me that has been burned into my memory ever since. "Doctor, he had been feeling all of this for over a year. He just didn't know that's what it was." I have been a physician for 21 years. I have seen many difficult stories in this profession. But the story of Robert, I'll call him that to protect the family, was one of the ones that changed me the most, both as a professional and as a human being. Because this was not a death caused by the absence of symptoms. It was a death caused by the absence of information. His body had been screaming for months. He simply didn't know how to listen, and no one around him knew how to translate. After his wife called, I spent days mentally replaying that appointment, trying to remember what I had asked, what he had said, what I could have pushed further. And it was during that review that I understood something that changed the way I practice medicine to this day. The signs were all there. He had them. He felt them. But he didn't recognize them as signs of anything. He thought it was just the life of a busy adult, normal tiredness, age catching up, the thirst that never went away. He figured he just wasn't drinking enough water, the frequent urination that woke him up in the middle of the night. He thought it was his prostate, the constant hunger that didn't stop after meals. He figured he was just anxious, the fatigue that didn't improve over the weekend. He blamed stress, the vision that had been blurry for months. He had scheduled an appointment with an eye doctor, canceled it 3 times. The sore on his heel that took almost a month to close, he covered it with a sock and forgot about it. The urinary tract infections that kept coming back, he treated them with antibiotics and moved on. The tingling in his feet at night, he thought it was just the way he was lying in bed. 9 signs, all present, none recognized. That is why I am here today. According to data from the International Diabetes Federation, there are more than 537 million adults living with diabetes in the world. It is estimated that nearly half of them don't know they have it. Half. These are millions of people carrying the same 9 signs that Robert carried, attributing each one to something else, waiting for it to get better on its own. My mission from this point in this video is simple: to show you each of these signs with enough depth that you will never ignore them again. Not in yourself, not in anyone you love. The first sign is excessive thirst, clinically known as polydipsia. We are not talking about the normal thirst of someone who forgot to drink water during the day. We are talking about a thirst that keeps coming back, that wakes you up in the middle of the night, that doesn't go away with a glass or 2 of water, that seems to come from a depth that normal hydration cannot reach. A thirst that becomes a daily, persistent, inexplicable presence for the person experiencing it. To understand why this happens, you need to understand what diabetes does to the body from the inside. When blood glucose is chronically elevated, persistently above 180 mmHg, the kidneys go into emergency mode to try to solve the problem. The mechanism is biologically sophisticated. The kidneys filter the blood and attempt to excrete the excess glucose through urine. That process, however, pulls a significant amount of water along with it. The body begins to dehydrate internally, even if the person is drinking what they consider a normal amount. The hypothalamus, which is the brain's thirst regulation center, detects this fluid imbalance and fires the thirst signal repeatedly and intensely. The person drinks. They feel temporarily satisfied. But because the root cause, the high blood sugar, has not been treated, the kidneys keep working in forced excretion mode, keep pulling water out, and the thirst returns within a few hours. It is a cycle that does not break as long as blood sugar stays elevated. And the problem is that it can go on for months, sometimes years, being blamed on everything: hot weather, salty food, stress, everything except what it actually is. Persistent excessive thirst, especially when combined with any other symptom on this list, is a sign that demands blood work. Not tomorrow, not next week, with real urgency. The second sign is excessive urinary frequency, known as polyuria. This symptom is a direct consequence of the first. When the kidneys are excreting excess glucose, they produce a volume of urine far above normal. A healthy adult produces between 1 and 2 liters of urine per day. An uncontrolled diabetic can produce 3, 4, even 5 liters in 24 hours. The body is literally trying to clean itself out, excreting through urine what it cannot process through metabolism. What makes this sign especially troubling in clinical practice is the nighttime pattern. During the day, a person might attribute frequent bathroom trips to how much they drank. But at night, when the body should be resting, when metabolism slows and urine production normally decreases, the uncontrolled diabetic keeps urinating. They wake up 2, 3, 4 times a night. Sleep fragments. Rest is never complete. This pattern of nocturia, excessive urination at night, is one of the most specific signs of chronic high blood sugar and deserves immediate attention when it occurs persistently in adults who never had this pattern before. The major mistake that happens with this symptom is confusion with other conditions. In men over 45, diabetic polyuria is frequently blamed on the prostate. In women, it gets attributed to recurrent urinary tract infections, which, as we will see later, can themselves be a consequence of diabetes. This overlap of symptoms delays the correct diagnosis by months, sometimes years. The key to identifying diabetic polyuria is in the volume and urgency. It is not just going to the bathroom frequently, but producing large volumes of urine each time with a sudden and intense urge, especially at night. The third sign is constant and disproportionate hunger, known as polyphagia. This is one of the most counterintuitive symptoms of diabetes because the person eats, sometimes eats a lot, and still feels hungry. To someone watching from the outside, it looks like anxiety, emotional eating, a behavioral problem. To the person experiencing it, it is a hunger that makes no sense, that doesn't respect mealtimes, that doesn't fully go away after eating. The explanation lies in the central mechanism of all diabetes pathophysiology, the inability of cells to use glucose as fuel. Under normal conditions, glucose from food enters the bloodstream. The pancreas secretes insulin in response, and insulin acts like a key that opens the cells to receive glucose. The cells have fuel, generate energy, and the body functions. In type 2 diabetes, the cells develop insulin resistance. The locks become defective. The key exists, but it no longer opens efficiently. In type 1 diabetes, the problem is even more radical. The pancreas stops producing insulin entirely, so there is no key at all. In both cases, the result is the same. Glucose circulates in the blood at elevated levels but cannot get into the cells. The cells are left without fuel. In a state of energy deprivation, they send emergency signals to the brain. The brain interprets those signals as hunger. The person eats. Blood sugar rises even higher. But the cells still cannot use that glucose. The hunger doesn't go away. The cycle repeats. A study published in Diabetes Care found that uncontrolled polyphagia in undiagnosed diabetic patients was associated with a 34% increase in the rate of insulin resistance progression. Ignoring this symptom doesn't just perpetuate discomfort. It actively accelerates metabolic deterioration. The fourth sign is unexplained weight loss. This is a symptom that deceives in a particularly cruel way because it can initially look like good news. The person sees the number on the scale go down without dieting, without exercising more, and interprets it as something positive. I have seen patients who lost 15, 20, even 25 pounds in 2 months and came into my office pleased with the result, until the labs showed a blood glucose of 480 mmHg. What is happening on the inside is not healthy weight loss. It is the body consuming itself to survive. When cells are chronically deprived of glucose as fuel, the body activates a metabolic emergency protocol. First, it mobilizes fat reserves, breaking down triglycerides to generate energy through an alternative pathway called ketogenesis. Then, when fat reserves begin to run low or when energy demand is too high, it starts breaking down muscle tissue, a process called protein catabolism. Muscle is literally dismantled to extract amino acids that the liver will convert into glucose. The visible result is rapid and unexplained weight loss. The invisible result is far more serious: loss of muscle mass, progressive organ compromise, and an acceleration of the entire metabolic deterioration process. This symptom is most pronounced in type 1 diabetes, where insulin production stops abruptly. But it also occurs in advanced stages of untreated type 2 diabetes. Unintentional weight loss greater than 5% of body weight in less than 6 months, without any change in habits, is a sign that demands immediate medical investigation, regardless of any other symptoms present. The fifth sign is extreme and persistent fatigue, clinically referred to as diabetic fatigue. This is probably the most universally ignored symptom because tiredness is such a common complaint in modern life that it rarely raises alarm. Stress, overwork, poor sleep, lack of exercise — there are dozens of convenient explanations for fatigue, and high blood sugar is rarely on the list of suspects. But diabetic fatigue has characteristics that set it apart from ordinary tiredness. It does not improve with rest. It does not respond to sleep, in part because, as we saw, nighttime polyuria fragments the sleep of the uncontrolled diabetic. It does not get better with vacations or long weekends. It is an exhaustion that seems to come from within, affecting not just physical energy but also concentration, short-term memory, and mood. The mechanism is straightforward. Without adequate cellular energy, every system in the body operates below capacity. Muscles become weak because they don't have enough fuel to sustain efficient contraction. The central nervous system operates in forced economy mode. The immune system functions poorly. The heart has to work harder to compensate for the increased viscosity of hyperglycemic blood. Researchers at the University of Oslo documented that patients with uncontrolled type 2 diabetes showed fatigue levels comparable to patients undergoing mild chemotherapy treatment. Diabetic fatigue tends to be most intense in the morning. The person wakes up already tired and worsens progressively over the weeks. When fatigue stops responding to any recovery measure and becomes the person's baseline condition, it is time to move past the convenient explanations and order the labs. The sixth sign is blurred vision. This symptom is frequently investigated in the wrong context. The person goes to an eye doctor, who examines the eyes, finds that the prescription has changed, and writes a new one. The problem may improve temporarily. Then it comes back. The person returns to the eye doctor. The cycle repeats, while the real cause is never addressed. The mechanism that explains visual blurring in diabetes is anatomical and precise. The lens of the eye, the natural lens that focuses images onto the retina, depends on an extremely delicate fluid balance to maintain its shape and refractive capacity. When blood sugar is chronically elevated, that balance is disrupted. The lens absorbs excess fluid through osmosis, its curvature changes, and the ability to focus becomes compromised. The world appears slightly out of focus, like looking through a wet window. What makes this sign especially deceptive is its intermittence in the early stages. Vision improves when blood sugar drops, worsens when it rises. The person may have days of reasonably clear vision alternating with periods of blurring, which reinforces the idea that the problem is eye strain or a need for a new prescription. But there is something even more serious that needs to be said about diabetes and vision. Beyond the lens, chronic high blood sugar progressively damages the blood vessels of the retina, causing diabetic retinopathy. This process is silent in the early stages. It doesn't hurt, it produces no dramatic symptoms. But it advances relentlessly when blood sugar is not controlled. Diabetic retinopathy is today the leading cause of blindness in working-age adults worldwide. According to the WHO, approximately 3 million people lose their vision each year as a result of this complication, and the vast majority of those cases of blindness could have been prevented with early diagnosis. The seventh sign is impaired wound healing, cuts and sores that take weeks to close, that get infected easily, that don't respond as expected to standard treatment. Two simultaneous mechanisms explain this phenomenon. The first is vascular. Chronic high blood sugar progressively damages the small blood vessels, the capillaries, that supply peripheral tissues. This damage is called diabetic microangiopathy, and it especially affects the vessels of the feet, legs, kidneys, and eyes. When the capillaries are compromised, blood flow to the distal tissues is reduced. Tissue with insufficient circulation receives less oxygen, fewer nutrients, and fewer repair cells. Healing becomes slow, incomplete, and vulnerable. The second mechanism is immunological. Excess glucose in the blood creates an environment that actively promotes the proliferation of bacteria and fungi. They also use glucose as fuel. At the same time, the immune cells responsible for local defense, especially neutrophils and macrophages, have their function compromised by hyperglycemia. They arrive at the wound, but they work with drastically reduced efficiency. The inflammatory response that should clean the wound and prepare it for healing becomes truncated. The practical result is devastating. Small wounds that in a healthy person would close in 3 to 5 days can take 3 to 4 weeks in an uncontrolled diabetic. And wounds that become infected can deepen progressively, reaching deeper tissues, tendons, and bone, a process called osteomyelitis, and evolve into situations requiring serious surgical intervention. Data from the American Diabetes Association indicate that approximately 60% of non-traumatic lower limb amputations in the United States occur in people with diabetes, and virtually every single one of those cases started with a small wound that took just a little longer to close, and that was ignored for too long. The eighth sign is increased susceptibility to infections, especially recurrent ones. This symptom shows up in various forms: urinary tract infections that come back repeatedly month after month, recurrent yeast infections, fungal infections on the nails or between the toes, gum infections that don't respond well to standard dental treatment, boils, and skin infections that appear with unusual frequency. The central mechanism is the same one that explains impaired wound healing: an immune system functioning below capacity in a glucose-rich environment that promotes microbial proliferation. But urinary tract infections deserve special attention. The kidneys of an uncontrolled diabetic continuously excrete glucose through the urine. That means the urine is permanently enriched with sugar, an ideal culture medium for bacteria. The urinary tract, which normally has efficient defense mechanisms, is constantly at a disadvantage against microorganisms that find an extremely favorable environment there. A study published in the Journal of Diabetes and Its Complications documented that patients with undiagnosed type 2 diabetes have a urinary tract infection risk up to 60% higher than individuals with normal blood sugar. This risk increases linearly with the duration of untreated hyperglycemia. Each month without a diagnosis represents an additional month of increased exposure. The pattern that should raise clinical suspicion is recurrence. A single urinary tract infection can have many causes. 3 urinary tract infections in 12 months in an adult male, or 4 or more in a woman in the same period, demands a complete metabolic workup. Not just treatment of the acute episode. The pattern of recurrence is the sign within the sign. The ninth sign is tingling, numbness or a burning sensation in the hands and feet, clinically known as diabetic peripheral neuropathy. This is, in my 21 years of experience, the most underestimated sign on this entire list. And it is particularly tragic that it is underestimated because it is also one of the earliest. It begins long before the damage becomes irreversible, and when identified in time, its progression can be significantly slowed. Diabetic peripheral neuropathy develops because the nerves that reach the extremities of the body are structures extraordinarily sensitive to the composition of the blood. Chronic hyperglycemia damages them through two simultaneous pathways. The first is metabolic. Excess glucose inside nerve cells activates the polyol pathway, which converts glucose into sorbitol. Sorbitol accumulates inside the nerve cells, causes osmotic stress, and produces progressive structural damage to the nerve fibers. The second is vascular. The tiny vessels that supply the nerves themselves are damaged by microangiopathy, causing progressive ischemia along the nerve fibers. The clinical result is a set of symptoms that patients describe in different ways: tingling at the tips of the fingers, a pins and needles sensation, burning on the soles of the feet especially at night, heightened sensitivity to light touch, or, paradoxically, areas of numbness where sensitivity has been reduced. Physicians describe the geographic distribution as a stocking and glove pattern, affecting the regions exactly covered by those garments, progressively moving up the limb. In advanced stages, the loss of sensation in the feet becomes permanent. The person doesn't feel when they injure their foot, doesn't feel the wound that has become infected, and by the time they notice, the process is already advanced. The data is clear. A large share of lower limb amputations in the United States are diabetes-related, and it all starts with a tingling that someone, at some point, ignored. Now that you know the 9 signs in depth, I need to tell you something fundamental that goes beyond each individual symptom. Type 2 diabetes does not appear overnight. Before it, there is a stage called prediabetes, where blood sugar is already elevated and damage is already beginning, but the formal diagnostic criteria have not yet been met. This stage can last for years, and during those years, all 9 signs can be present in milder forms, constantly being attributed to other causes. The hemoglobin A1C test is the exam that changes this picture. Unlike a fasting blood glucose test, which shows blood sugar at that specific moment, the A1C reveals the average blood sugar over the past 2 to 3 months. Values below 5.7% are normal, between 5.7% and 6.4%, prediabetes. Above 6.5%, diabetes confirmed. At the prediabetes stage, reversal is completely possible. The Diabetes Prevention Program, a landmark study published in the New England Journal of Medicine, demonstrated that lifestyle changes reduced progression from prediabetes to type 2 diabetes by 58%. No medication, just diet, physical activity, and weight control. But that only works when the problem is identified, and identification depends on a simple, accessible test available at any lab in the country, ordered by any doctor, performed at community health centers across the United States. The test that can change the course of someone's life is inexpensive and takes 10 minutes. The only barrier between those who get it and those who don't is information. You now have that information. Use it. Before I finish, I want you to do one thing. Just one. Think of someone in your life you have noticed seeming more tired than they should be, waking up in the middle of the night to go to the bathroom, complaining of constant fatigue, dealing with a wound that took way too long to heal, feeling tingling in their feet and blaming the mattress. Someone you look at and think, something is different, but you can't quite name what. Send this content to that person, not as a scare tactic, as an act of care, as information that can change the course of a story before it reaches a point of no return. because I cannot go back in time and give the right information to Robert before that Tuesday morning. But you can do that for someone in your life today. This channel exists for exactly that, to translate what medicine knows into language that any person can understand and apply. In the next videos, I will talk about the differences between type 1 and type 2 diabetes, about how to reverse prediabetes, about what really happens in the pancreas when you eat refined carbohydrates late at night, and about the tests every adult should get once a year that almost no one actually gets. Subscribe to the channel right now and hit the notification bell. Every video here is built with the same purpose, to arrive before the late diagnosis, before the serious complication, before the phone call no doctor ever wants to receive. Robert didn't have to die without knowing. With you here, someone you love won't have to either.